Good morning, everyone. Very much happy to welcome you to the Young Physicians Forum presentations for the month of May. Today we have two presenters, and just a notice to the presenters that your lectures be within 25 minutes, keeping 5 minutes for the questions. So if it's for running time, I'll give a warning to stop and start the question time. And I welcome all of you to the session, both physically and who are joining virtually. And to start with today's proceedings, I would like to invite Dr. D.K. Javira, a senior registrar in respiratory medicine from the National Hospital for Respiratory Diseases, Valisara. He'll be talking to us on pulmonary diseases in immunocompromised host. Over to you, Dr. Javira.
Good morning, everybody, and thank you very much for the kind words of introduction. So I'm going to discuss the rather important topic. This is actually not relevant for a respiratory physician, but not for the physicians in the internal medicine, but it is important topic for all the subspecialties, including rheumatologists and the surgical teams and the anesthesiologists and everywhere. Why I'm mentioning that? Because immunocompromised hosts are managed by not only us, because all the patients are referred from us from the other subspecialties as well. So, and other important thing is there is a rising number of immunocompromised hosts due to the infections like retroviral infections and some advancement of the management, right? Interstitial lung disease are newly diagnosing, and there are a whole lot of transplantation occurring worldwide. So therefore there are a lot of patients are coming. So this is a very important topic for all of you. So with keeping in mind, so I'll start with the case presentation. This is a 26 years old lady who presented with the recurrent respiratory tract infection. At age of 7, she had a bronchopneumonia which was treated with IV antibiotics, and following that also she had various organisms which were positive with the Pseudomonas coliforms and Staphylococcus. And at the age of 20, she has to undergo left upper lobe lobectomy at the age of 20. Following that also she had a TB infections and invasive Aspergillosis infection, and following she had developed the left upper lobe bronchiectasis, and she underwent left upper lobectomy at the age of 25. And so after that, patient was referred for the further evaluation. So this is the CT scan. So you can see, so there are, this is before surgery. So you can see the focal bronchiectasis changes mainly on the left upper lobe. So we did some basic investigation. Full blood count was normal. Output neutrophil was normal. CRP was little elevated, 68. ESR was 32. Renal and liver functions all came negative. So we did retroviral screening. So it came negative, and we did some specific tests. So anti-tetanus toxoid antibody test for IgG test, antibody test, and nitroblue test for the neutrophil function test. Everything came normal, and we did the complement level, that also came normal. Finally, we found that when we did the serum Ig immunoglobulin level, she had a severe deficient IgA deficiency. So this patient diagnosed to have severe IgA deficiency. So this she leads a lot of complication, and finally she had to end up with the left upper lobectomy. So this is my topic outline. Next 20 minutes, I will discuss some epidemiology of pulmonary diseases among the immunocompromised hosts, and I will discuss some basic defense mechanism in the respiratory tracts and type of immunodeficiencies and their etiologies, and the complications of lung complications in the immunocompromised patient. It could be infective or non-infective complications, and finally I will discuss the basic management points. So epidemiology, actually, sorry, I could not be able to find any Sri Lankan data regarding the immunosuppressive patient data, but this is US data. So it has mentioned there are 8 million people who are having newly diagnosed to have suffer from the immunodeficiency. And there are important thing, other thing is there are more than 400,000 pneumocystic Jerovirus infections occurring in HIV-positive patients, and more than 100,000 pneumocystic Jerovirus infections present in newly diagnosed in non-infective HIV patients as well. Another important thing is more than 100,000 new organ transplant happen in worldwide per year. So the most important thing is when there is immunosuppression, lungs are the most commonly affected organ system. So what is immunodeficiency? Immunodeficiency is a state in which the ability of the immune system is compromised or entirely absent to the fight against the infection, diseases, or the cancers. So this could be a primary or the secondary. Usually the immunodeficiency again can divide it into specific or non-specific, but usually when there is a secondary immune deficiency, it is usually the non-specific. So what are the causes for this immunodeficiency? So there are a wide variety of causes: the malnutrition, the infections, and environmental stressors, and the extremities of the ages, and the following surgery like a splenectomy. And the important other point is the immunosuppressive drugs due to the following transplant or following diagnosis of the interstitial lung disease, connective tissue diseases like that. So that's why at the beginning I mentioned, so this is not a, the immunodeficiency is a hot topic for all subspecialties and all of us. So what are the basic innate immune defense mechanisms in the lungs to prevent the infection? Because it is important, we usually for the 24 hours, we take 10,000 liters of air into our respiratory system. This contain a lot of bacteria, viruses, and particles. But the cilia and the mucus plug will trap everything, most of the thing. But only the very, very small particle will reach to the alveolar level. Once it is reached to the alveolar level, that part is also engulfed by the alveolar macrophagia. So this is very efficient system to prevent the infections. So there are several types of immunodeficiencies. So one category is the B lymphocyte deficiency. Usually this occurs following the lymphoproliferative disorders or hypogammaglobulinemias and drugs like steroids. When there is a B lymphocyte deficiency, usually the encapsulated organisms like Streptococcus pneumoniae, Pseudomonas aeruginosa are the most common infective organisms in these types of immune deficient patient. But when there is a T lymphocyte deficiency, it is usually due to the lymphomas, renal insufficiency, or HIV or AIDS, and drugs like steroids. So then usually the intercellular organisms like cryptococcal and other fungi, mycobacterial infections, herpes infections are the most common. And other subcategories impaired granulocytes by the myeloproliferative disorders or drugs like steroids. So then our normal common cell bacteria will infect at that point of view. So what I want to highlight here is that drugs like steroids, which are widely used in many patients. So they can affect B lymphocyte function, T lymphocyte function, and that cause neutropenia as well. So when the patient comes with the pulmonary involvement, in the immunocompromised patient came with the pulmonary involvement, so they can be divided into infective causes and non-infective causes. 75% of patients are having infective causes, but 25% they are not infective. So what are the infections? As usual in the immunocompetent host, this could be a community-acquired infection, like a Streptococcus, Haemophilus, or respiratory viruses. But problem occurs when it is affected the immunocompromised, so the severity is different. They are having more severe disease, and they are having drug resistant, and their presentation is usually atypical. So that's the main. And they are having a lot of nosocomial infection as well, because these patients are having a lot of previous hospital admissions, because they are taking this infection from the hospital setting. The escape group of organisms like Enterococcus faecalis, Staph aureus, Klebsiella-like infections are very common. The main problem is these organisms are mainly having the drug-resistant forms. And other important thing is the reactivation of the infection. It could be viruses, bacteria, or so in lungs wise. So most important one is the TB, latent TB infections. And environmental exposures. Usually these environmental exposures are usually they won't cause any diseases in immunocompetent hosts, but when it is affected to the immunocompromised host, they can cause severe diseases like non-tuberculous mycobacteria, Legionella, and parasites. So you see, so there is a whole lot of causes for this, the infective causes for this immunocompromised host. So I can't do, I think 10 minutes. I can't cover everything within 10 minutes. So I'll take some real case scenarios we have managed in these patients at NHRD Valdisar these days. So this is interesting patient. This is a 25 years old lady who presented with a fever, cough, SOB for 2 weeks duration. And she didn't come up with her past medical history at the beginning. So then she had a severe exertional desaturation as well. So we did some basic investigation. WBC was 14,000 with neutrophil predominant with high CRP. And sputum culture came both coliform was positive, and sputum acid fast bacilli also came for positive. And this is the chest X-ray of that patient. So there is a patchy ground glass opacity is mainly distributed in the both lung, but it makes more in the right lung. So since this was abnormal, so we investigate this patient further. So we did the HRCT also, there is a perihilar ground glass opacity. So it is this appearance is very characteristics of the pneumocystic gyrovasi pneumonia. And we did a retroviral screening. At that point, we come to know this patient was diagnosed patient of HIV, and she has defaulted treatment, and she comes with a cough and SOB. So we initiate treatment with the IV broad spectrum antibiotics to cover the coliform infection, and we started anti-TB drugs, and we started the treating for the cotrimoxazole for the pneumocystic gyrovasi infection. So regarding few important things about HIV and the pneumocystic gyrovasi. Usually this pneumocystic gyrovasi infection occurs when their CD4 count is less than 200. And usually their main important clinical signs is the exertional desaturation is a typical findings. And other important thing is this usually pneumocystic gyrovasi infection coexist with other infection like TB, sometimes it is cytomegalovirus. So we have to investigate for other infections as in this patient. So she had a TB, coliforms, and the pneumocystic infection as well. And usually we can diagnose if the clinical history is suggestive or the typical radiological appearance. And we can take some idea from the increased LDH and beta D glucagon level also elevated in these patients. So they are supportive evidence. The best sample for the diagnosis is a bronchoalveolar lavage. So we can do the silver stain or PCR for the confirm the diagnosis. Treatment is usually with the trimethoprim sulfamethoxazole. Usually depend on the patient clinical situation. It is usually 14 to 21 days. But if the patient is having sulfur drugs allergies, we can use alternative like dapsone, pentamidine, or clindamycin plus primaquine combinations. The most important thing in the HIV patient with pneumocystic gyrovasi, so we have to give some adjuvant steroid therapy. Patient who are having PaO2 of less than 70 or arterial alveolar oxygen gradient was more than 35. And the TB and the HIV. Initially, I mentioned the pneumocystic gyrovasi usually occurs when there is a CD4 count less than 200. But the important thing is this TB infection can occur at any CD4 count. But the important thing is the clinical presentation is usually depend on whether it is early disease, early retroviral disease or late disease. If CD4 count is normal, that means more than 350, they usually present with the open cavitated lung lesions. But when there's a late disease, they will present with a pulmonary infiltrate. So then often the sputum smears also become negative in this kind of patients. And when there is a TB and HIV co-infection, so our priority is to start the anti-TB drugs first. And then we have to start the antiretroviral treatment within 2 weeks of starting anti-TB treatment. Each and every patient should undergo gene expert and TB cultures for identifying drug-resistant TB forms. Another important thing is in the TB, there can be a paradoxical exacerbation of symptoms and signs and radiological manifestation once we have started antiretroviral therapy. So this is called immunoreconstitution syndrome. So we have to be cautious about this, but usually most of the time these are usually self-limiting, sometimes non-steroidal anti-inflammatory drugs or rarely steroids might warrant. Yeah, so this is another case. So he's a 57 years old male who presented with a cough and SOB for three months duration. He didn't complain any fever, but he had a loss of weight and loss of appetite. And we did, so this is the chest X-ray. So chest X-ray shows there is a bilateral cavitated, thick wall cavitated lesions in both lungs. So we did a full blood count. It shows WBC was normal, CRP normal, ESR was 30, and all the TB investigation came negative. So we did a HRCT test also. It also shows bilateral thick wall cavitated lesions. Since our country is the TB prevalent disease with a clinical suspicion, we started anti-TB drugs as well. But after 2 weeks or after anti-TB drugs, patient didn't have any response. So therefore we did a fiber optic bronchoscopy for this patient, and we sent the sample for the bronchial lavage for the cryptococcal antigen for this patient. The cryptococcal antigen came positive. And while doing that, since this was an atypical presentation, we did a retroviral screening. Retroviral screening was positive, and at that time, the CD4 count was 74. So this is a cryptococcal infection with an undiagnosed HIV infection. So we treated this patient with amphotericin. So other treatment is available is flucytosine or fluconazole also we can use. Other important thing is in cryptococcal infection, usually they occurs when the CD4 count is less than 100,000. And so this is another interesting patient. So this patient is a 60-year-old male who presented with the end-stage renal disease who was on regular dialysis. And he presented to us with a cough and shortness of breath with low-grade fever for 2 weeks duration. On admission, patient was dyspneic and tachypneic. So we did a chest X-ray. It shows there are thick wall cavitated 2 lesions in the right side of the lung. And we did a HRCT of chest, so that also same the same things. So when we did the full blood count, it shows WBC count of 3,200 with the neutropenia. And CRP was high, ESR was high, serum creatinine was anyway, his baseline was little elevated. And we did a fibroptic bronchoscopy for this patient and TB investigation, everything came negative for this patient. And for this serum galactomannan and the Aspergillosis IgG, they came positive. And we treated this patient as an invasive Aspergillosis. Regarding few things about neutropenia. This is the neutropenia is the most common risk factor for the pulmonary infection. The neutropenia could be acquired, it could be due to acquired causes or it could be congenital causes as well. So when there is a neutropenia, it will predispose to the infection from the endogenous bacterial flora. Usually the severity of the disease is depend on the duration of neutropenia and the absolute neutrophil count. If the absolute neutrophil count less than 500, it causes severe neutropenia, it can cause a severe disease. Regarding pulmonary aspergillosis, actually pulmonary aspergillosis is a spectrum of disease. It depends on the clinical presentation, depending on the host immunity. If the patient is immunocompetent host, then they can cause ABPA and allergic bronchopulmonary aspergillosis or severe asthma. But when the patient is immunodeficient, then they can cause invasive aspergillosis in that patients. So how do you diagnose invasive aspergillosis? For the proven of the invasive aspergillosis, we have to do tissue histopathology should be positive in the sterile sites. But usually, so that's how we have to come to the diagnosis of proven invasive aspergillosis. But most of the time, this could not be able to done. Usually, we are doing some supportive evidence from the host criteria. If the patient host is having some immunodeficient features with some clinical criteria, including radiological appearance, so then we can diagnose it as a possible invasive aspergillosis. But for that, if patient is have microbiological criteria like positive cultures or positive galactomannan test, so then we can do this probable invasive aspergillosis. So usually these patients are treated with voriconazole, or if the patient is having severely ill, so we can use IV amphotericin as well. Another important thing is the cause for this immunosuppression. If we could reduce the steroids dose, or we could reduce the immunosuppressive dose, that is also play an important role in managing this kind of patient. And surgical debridement is recommended if there is a not responding to the treatment. So this is another patient. So he's a 33-year-old male who had underwent renal transplant twice in 2012 and 2021. After the second transplant, he had developed the extrapulmonary TB, which was treated with anti-TB drugs. So after 1 year, that patient had developed the chest wall abscess. So we did a abscess drain pass. So it just came as a TB gene expert was positive with the rifampicin resistant forms. And during that time, we did a sputum examination also. It came as a sputum acid fast bacilli positive, but TB gene expert came negative. So HRCT also shows there is a diffuse strain bud appearance. So as I mentioned earlier, so this immunocompromised host has a lot of complication of the TB. So there is a atypical complication, TB pyomyositis, and there is a drug-resistant TB organisms. And other thing is there is a mycobacteria other than TB infection in this patient. So what is this mycobacteria other than TB? So it is usually other than the Mycobacterium tuberculosis and Mycobacterium leprae. There are more than 100 organisms are found, 100 species are found, but usually they won't cause any disease in immunocompetent hosts. But when it is affected to the immunocompromised host, it can cause pulmonary disease or lymphadenitis or disseminated infection. The most important thing is in this patient, usually the diagnosis is confirmed by this positive culture report with antibiotic sensitivity. For empirical treatment, we are starting using the macrolide antibiotic and rifampicin plus ethambutol. Usually these patients need long-term antibiotics more than years. Yeah, so now I discuss some important infective organisms that can affect in immunodeficient host. Then, if the patient presented to you with a immunodeficiency state with a pulmonary infection, how do you evaluate? Most important thing was the history and the examination. The age of onset is very important, and the family history and the past medical history and the past illnesses. So those are the very important things. When you are investigating, first of all, you have to investigate with the basic investigations. You have to full blood counts, with the WBC counts and blood pictures to see any atypical cells, and quantitative immunoglobulins, antibody titers, and skin testing for the hypersensitivity reactions as well. And most of the time, we should not forget these common things are common. The poorly controlled diabetes also are immunocompromised. So the HIV screening, cystic fibrosis, and the primary ciliary dyskinesia. If everything is negative or no, so then we can give for the specific test. So IgM antibody function test, IgG antibody titers, and skin testing for the candida skin stat for the assess the T cell functions. And other most important thing is evaluating this kind of patient is a radiology. It is a chest X-ray and the CT scan, HRCT chest. So, but most important thing is here this radiology. This should be reported by very veteran radiologist. Then he or she can give a lot of information regarding the infection. For example, if there is with a clear history with a bilateral perihilar ground glass opacities is more common in a pneumocystic cerevisial infection like that. So therefore, the radiology play an important role in this kind of patients. So now, how do we manage these patients? The main important thing is the prevention. Always we have to avoid the environmental exposures, and we have recommended these patients with the vaccination again, pneumococcal, meningococcal, hepatitis, and influenza vaccines. And we should avoid these patients vaccinating in live attenuated vaccines because they can cause a severe disease. Another important thing I have forgot to mention here is the prophylaxis antibiotic. If it is indicated, so we can start prophylactic antibiotic prophylactics for the prevention, and maintaining good oral hygiene. So it will prevent the recurrent respiratory tract infection. It has a proven evidence. So the maintaining oral hygiene is very, very important in prevention of the recurrent respiratory tract infections. And when this patient anyway presented with acute infection, so we have to manage this patient vigorously. Antibiotics, antivirals, and antifungals we have to give. And so the other important thing, if we could discontinue or reduce the dose of immunosuppressive that lead to the immunosuppression state, so that is also very important. And chest physiotherapy and early mobilization will improve the patient mobility. And so now I previously discussed about some infective involvement in the lungs in the immunocompromised host. Now I will discuss what are these non-infective pulmonary involvements, because 25% of patients who presented immunocompromised host present with the pulmonary infiltrate, this could be non-infective as well. So the first thing is the extension of the underlying disease. That means the metastasis, usually breast, colon, prostate carcinoma. Usually sometimes they can present with some cannonball opacities in the lung. So that's how they have they have diagnosed. Another thing is leukemic patient. They can present with the pulmonary hemorrhages. And some leukemic patient, they can have this severe hypoxemia, which could not be explained by any other causes. Then it might be due to the leukocytosis and occlusion of the blood vessels in the lung. So it can cause pulmonary infarction and severe hypoxemia in this patient. Another important thing is the pulmonary reaction to the drugs that we are giving for these immunocompromised patients. The drugs can cause direct reaction with the lungs. So what are those? The amphotericin, sulfonamide, and nitrofurantoin can cause bronchitis. And methotrexate and nitrofurantoin, it can cause organizing pneumonias. And amphotericin, amiodarone-like drugs, they can cause pulmonary edema. And so some drugs can cause pleural effusions, like drugs like nitrofurantoin and amiodarone. So therefore, the drug reactions is also very important in this kind of immunosuppressed patients. So we have to consider when it comes with the pulmonary infiltrates. And sometimes the other category is the new unrelated disease process which affect the lung. That means patients who are taking long-term immunosuppressive, they are having increased risk of development of primary lung carcinoma. So that's one thing. Another thing is they are having high risk of developing pulmonary embolism, pleural effusions, and aspiration pneumonia because prolonged immobility and prolonged bedridden duration. So these complications also we have to think about. So finally, these are my take-home messages. The number of patients with immunodeficiency are rising globally. And lungs are the most commonly affected organ in the immunocompromised host. Lung involvement could be due to infective or non-infective infections. When it is occur, it is more severe and atypical in presentation. Non-infective pulmonary involvement occur in 25% patients of the immunodeficiency. And prevention of infection with vaccination and prophylaxis antibiotic, maintaining good oral hygiene, and will play the important role in these patients. So President Ceylon College of Physicians for giving me this opportunity to talk in this young physician forums. And thank you very much for the colleagues and the patients who gave their valuable details for this presentation. Okay, thank you very much.
It is open for discussion questions. If you have any questions, please. Mike.
Yeah, thank you for that conspiracy information. This was it's sensitive to all the drugs. You used it in the usual way, or you continue for a longer period, or
No. Anyway, we'll send the culture survival starting the treatment, but anyway, that usual treatment, we are treatment.
So it's the standard treatment.
Yes.
Other thing I want to ask is, if you are giving prophylactic antibiotics for patients who, immunodeficiency patients on the respiratory tract, what is the prophylactic antibiotic you recommend and how long you?
Actually, sir, it is depend on for the some patients for the especially so the pneumocystic prophylaxis, sir. Usually we are giving with the cotrimoxazole, sir. So then we have to continue until the immunosuppression treatment is over. And for the bronchiectasis patient for who are having recurrent respiratory tract infection, so we'll give azithromycin. So azithromycin is the next one. So depending on the disease, the prophylactic antibiotic is differs, sir.
No question from the audience. You briefly mentioned about the immune reconstitution syndrome in patients with HIV and TB when they are on the infiltrate drugs after 2 weeks of the NCD drugs. Are there any criteria to diagnose that, or is there a clinical observation?
Yeah, it is mainly a clinical observation, but the important thing is we have to exclude the other possibilities that can worsen the disease. And after exclusion, so the clinical diagnosis comes as a immune reconstitution syndrome, sir.
No definite criteria?
No.
There are two questions. Is there any recommendation say that you have started taking drugs in all patients who are started on HIV?
No, sir. No, sir. We have to evaluate this all the HIV positive patients for the active TB infections and the latent TB infection very rapid way. We have to do everything and we have to exclude those things, but we are not starting the treatment, sir.
And do you start antibiotic E. coli still come positive?
No, sir. It is depend on the clinical situation. If the patient is asymptomatic and inflammatory markers are normal, we are not treating for actually for the lab reports.
Any more questions? Thank you very much. There's a certificate of appreciation.
Thank you.